Hey everyone, my name is Marty Piazza. I'm one of the neurosurgery residents at UNC, and welcome to the Neurosurgery Med Student Primer Series. We developed this series in order to help prepare students for their clinical rotations. It's not meant to be an exhaustive review of the topics that we cover, but hopefully it'll give you a basic foundation and context for some of the commonly seen pathologies you'll come across during your rotations. Today we're going to be talking about IVH of prematurity and hydrocephalus. So some general information, IVH of prematurity occurs in 12,000 premature infants per year in the US alone. 67% of infants born between 28 to 32 weeks and 80% of infants born between 23 and 24 weeks will develop IVH. And not surprisingly, it's associated with a higher mortality rate. The source of the hemorrhage itself is in the germinal matrix in the periventricular caudothalamic groove. It's a collection of neuronal glial precursor cells, and it has frail blood vessels that are at risk for bleeding. These vessels surround the ventricle, but they're most evident at the caudate head. At 32 weeks, these cells are only present at the caudothalamic groove, but there's still a risk of hemorrhage in the first 48 hours after birth. By 35 to 36 week gestation, the germinal matrix is gone, so the risk of hemorrhage drops significantly by this age. Other than prematurity itself, IVH of prematurity risk factors include vaginal delivery, low APGAR scores, severe respiratory distress syndrome, pneumothorax, hypoxia, hypercapnia, patent ductus arteriosus, thrombocytopenia, infection, and sepsis. So grading of IVH. This is something that you may get asked about on your rotation, so it's good to have a general idea of this. But there are 4 grades of IVH from low to high severity. Grade 1 is the best prognosis. It's restricted to the subependymal region in the caudothalamic groove and the germinal matrix itself. And you can see the hemorrhage right below the letter B is that hyperechoic area is the hemorrhage. And then, like I said, these patients have a good prognosis. Grade 2, there's actual extension of blood into the ventricles, but there's no ventriculomegaly. And importantly, there's less than 50% of the ventricle filled with blood in this scoring. These patients also have a good prognosis. Grade 1 and 2 patients usually don't require surgical intervention, and in our institution, we don't even get called about these. Grade 3 IVH, there is interventricular blood and ventriculomegaly. There's a 20% mortality rate in these patients. And you can see that here, those ventricles are enlarged. And a grade 4 IVH is the most severe, and it has the same criteria as grade 3, where there's IVH and ventriculomegaly, and there's also an intracerebral hemorrhage. And there's a 90% mortality rate with this type of hemorrhage. Now, it's important to note that the intracerebral hemorrhage in the grade 4 IVH is not because blood is blowing out from the ventricle into the brain tissue itself, but rather that there is compression and venous congestion of the deep terminal veins, and that causes venous infarcts and in turn hemorrhages in the brain itself. So some sequelae of IVHs. As I mentioned before, the higher grades are going to be associated with perihemorrhagic infarcts, particularly the grade 4s. Cerebral palsy and also developmental delays are common in these higher grades. There are also still risks of developmental delay in the milder IVHs, but to a lesser extent. Interestingly, some studies are showing that there are better functional improvements in the moderate to severe IVHs, and we attribute that to improvements in neonatal critical care practices and the multidisciplinary approach to these patients. So now that we've talked about the pathogenesis and the grading system of IVH, let's talk about diagnosis and how to perform a neurosurgical evaluation of these patients. As you probably figured from the previous images I showed you, this is something that's typically diagnosed by ultrasound. Premature infants will routinely get head ultrasounds as part of their initial workup. At our institution, we typically won't get called about grade 1 or grade 2 IVHs, like I mentioned, but grade 3 and grade 4s can have some significant signs and symptoms for which we'll get called about pretty early on. Almost all of the things that I'm going to talk about are clinical manifestations of increased ICP in an infant. That exam is quite different from what we would see in an adult because they won't show typical ICP findings like blown pupil, hemiplegia, Cushing's response, those types of things that you would see in someone who's older or in an adult. And the reason for that is because they've got open sutures and their bones aren't fused, so they can tolerate an increased pressure in a gradual sense. That being said, there are very consistent but more subtle findings that indicate elevated pressure in these patients. The first one we look out for are apnea and bradycardic events, and this is kind of like a modified Cushing's response, is the way I think about it. Bulging Fontanelle, so they've got that soft spot, so we can actually feel the pressure in their head just by feeling the Fontanelle itself. And then you also see splaying of sutures, the bones are spreading apart more, and going along with this also there will be increasing head circumference. Typically we'll be getting daily head circumferences on these patients to help trend this. And then also you may see posturing in these patients, and this can indicate that the patient is having seizures, which is a sign that their pressure could be elevated as well. So patients that have the findings we discussed in the previous slide typically require neurosurgical intervention in some form or another to treat their hydrocephalus, which is increased pressure in the brain. They will oftentimes get daily head circumferences to help trend the size of their head, weekly head ultrasounds to help better characterize the blood pattern if it's evolving. And then we oftentimes will get a high resolution T2 MRI, which is oftentimes called a CISS, a KISS sequence, or a Fiesta sequence. And this basically just depends on the brand of MRI your institution has. And the reason why we get this MRI is to help plan for future CSF diverting procedures. The first step in managing a patient that has concerning clinical findings of hydrocephalus from IVH is to perform a ventricular tap. And this just acutely relieves the pressure. It doesn't give any lasting effect. The pressure is going to build up again unless we do something more definitive, but it buys us some time to see if the patient will be able to tolerate a more definitive procedure later on. Patients that require repeated ventricular taps but are too small for more definitive procedures may receive a subgaleal shunt, which I'll talk about that more specifically later. And then an ETV, CPC, and shunts are the definitive treatments for hydrocephalus. And we'll talk about all these a little bit more in the coming slides. So for a Fontanelle tap, you want to find the right anterior lateral corner of the anterior fontanelle in the mid-pupillary line. You'll take a butterfly needle and pass it into the ventricular space. While draining, you want to watch for vital sign changes, specifically tachycardia and a sunken fontanelle. And then typically the teaching is that you want to drain no more than 10 cc's per kilogram. It's kind of like the safe guideline. However, you can drain more. You just have to make sure that you watch for seizures and electrolyte shifts. So you want to make sure you're in close communication with your ICU team to make sure that they know that you're taking off a little bit of extra fluid. And then obviously you always want to clean off the betadine afterwards because it can be quite irritating to the infant's skin. So if a patient is too young for a definitive CSF diverting procedure like a shunt or an ETV, usually that's less than 1 month of age, or they're too small, they're less than 3 kilograms, then we can put in a subgaleal shunt. Basically, it's comprised of a ventricular catheter and an open-ended subgaleal distal catheter, and we'll create a subgaleal pocket that allows CSF to drain into that subgaleal space, and it causes this quite pronounced bulge on the head. This fluid will get absorbed over time, and eventually the skin will scar down and the subgaleal shunt fails. Typically, we say it lasts around 40 days. It can last longer, it can last less, but this is not a definitive procedure. It's meant to kind of temporize things until the patient is either big enough or old enough to tolerate a more definitive CSF diverting procedure. So an ETV CPC, or an endoscopic third ventriculostomy with choroid plexus cauterization, is a procedure that allows us to avoid permanent hardware placement by fenestrating the third ventricle into the prepontine space. And we do this in order to directly visualize the subarachnoid space. Here on the left you can see the foramen of Monroe on the upper left-hand corner, and then the floor of the third ventricle is that that dark spot with the mammillary bodies right behind it. And then when we fenestrate this floor of the third ventricle, we want to get into that subarachnoid space and get what we call a naked basilar artery. And that means that we see the basilar artery without a membrane in front of it. And that membrane is called the membrane of Lilliquist, which is a folding of arachnoid. And if we can get behind that and get that naked basilar, we'll be in the subarachnoid space and potentially achieve better success with our ETV. The ETV can be revised several times, but usually after the second failure, we have to put a permanent hardware or a shunt in these patients, which we'll talk about on the next slide. On the right-hand side, you can see the ATV success score. I'm not going to go into too much detail about it, but for the purposes of the IVHs, just know that at 1 month or before 1 month, there's only a 20% success rate, which is really low. And if we can get them past 1 month or even older, that success rate goes up. So if we get them to 1 month, it's still only a 30% success rate, but it's better than 20. So we do whatever we can to kind of get them to that 1 month marker before we try our first ETV if possible. So if a patient fails multiple ETVs or requires permanent CSF diversion less than 1 month of age, will require a shunt placement. Typically, we start with the ventriculoperitoneal shunt, which involves a ventricular catheter, which is attached to a valve, and that valve controls the amount of CSF that is drained, and then a distal catheter that drains CSF into the peritoneal cavity. All of this hardware is underneath the skin, and if for whatever reason there's a hostile abdomen or the patient's abdomen isn't amenable to putting a peritoneal catheter in there, you can occasionally use a pleural space or the atrium of the heart to drain CSF, but the go-to is always going to be the peritoneal cavity if possible. This is not a perfect system and carries with it lifetime risks of failure. On average, we tell patients that patients with shunts will have at least 3 or an average of 3 revisions in their lifetime. However, I've seen patients that have had 0 revisions in their lifetime, and I've had patients that have had hundreds of revisions in their lifetime. So it's something that you constantly have to be worried about in these patients. And in the first year, no matter how well you take care of the wound or how good your sterile technique is, there's a 5 to 10% infection risk. And that infection requires, taking out the entire shunt, putting an EVD in, hospitalizing the patient while we figure out what bacteria is growing in their shunt and treating them for it before reimplanting the hardware. So it's quite a big deal if the patient does get infected. So if we can avoid ever putting in these systems in the first place and get them, a successful ETV, that's always preferable, but sometimes it's just not possible. So here are our references, and please follow us on Twitter at UNC Neurosurgery for more future educational content.